okay? And rotator cuff is not just like this. It has what's called a wide footprint, and it fans out, okay? Now, why is that important? The guy that wants to do with the weekend warrior stuff, lots of circumduction, lots of range of motion, they can tear their rotator cuff apparatus fairly quickly, okay? Partially or completely so. All right, internal rotation, and I didn't have a baby arm view on this one. TP is teaching point, as you know. This is calcification where there shouldn't be calcification. And anatomically, what area am I in?
What do you mean?
The joint capsule.
Joint
The
capsule?
glenohumeral joint.
Glenohumeral joint, and inside the glenohumeral joint is the subacromial / subdeltoid
Bursa.
Bursa.
Okay? Now, the subdeltoid bursa is going to be more like this, but sometimes they have a communication. But the subacromial and the subdeltoid cause bursal calcification. Now, how do I know it's bursal versus capsule? I don't, but I need to know the difference between bursal calcification, which remains constant in position, meaning if I do this, and I do this, and this calcific density stays the same, that is bursal. If I have, on external rotation, this density moves into a different position, it's following the tendon because it's in the tendon. So tendinous calcification moves with internal and external rotation. Bursal calcification stays constant, all right? Then you send them to your orthopedic surgeon, they put in a small gauge needle and a bigger gauge needle. This is like toothpaste, it gets sucked out. If the patient doesn't stop their repetitive activity, a month later you can x-ray it, and they will have a lesser degree of calcification, but it's just aggravated it. The bursa is inflamed, and now the calcific salt's infiltrated, and that's how you get this radiographic appearance. All right?
Mm-hmm.
So tendinous versus bursal calcification. On MRI, sagittal or coronal or axial?
Axial.
It
Is
looks
it?
like coronal, okay?
Mhm.
So just to be sure, okay, it's like this. All right, the landmarks where I've got the triangles in red, that's labrum. And that's the orientation of the labral portion of your glenohumeral joint. It's lined with fibrocartilaginous, and on either end, they are triangular. This is what the signal intensity looks like of the body of the supraspinatus, and then it should become dark. And there's an area here of linear increased signal intensity. That's not normal. Now, it could be age-related, okay? It could also be a tear. So tears can occur superior inferiorly or within the body of the tendon. And we're getting ahead of ourselves. I just want you to know what they're looking for on the MRI if it happens to deal with rotator cuff injuries. Now, they get more than just a coronal plane, they'll have a sagittal plane and an axial plane, but all roads lead to what's the status of the rotator cuff. Okay? Just so you know, small tears, they'll talk about the bursal surface, where the versus the non-bursal surface is an intersubstance horizontally, and its size. If it's small, and every orthopedic surgeon has a different idea of what small is, but let's say 5 millimeters in size, that's conservative care, it'll scar on its own. If it's torn from one side to the opposite side, that needs surgical intervention. They go in and stitch it together. Okay, usually arthroscopically, unless the surgeon says, I don't want to, however he has been trained and however he wants to do that. All right, so MRI imaging. Body part?
Left hand.
Left hand, so we're gonna show you how to take an x-ray of a hand, shoulder, clavicle, elbow, and wrist, as well as the hand. All right, where's the abnormality?
Fracture.
The fracture.
Okay, so before we get to fracture, the teaching point is find something that is normal. Okay, don't let this throw you. This is just what the inferior aspect of the underside of the metacarpal head looks like. So normal, normal, normal. Okay, normal shaft, absolutely abnormality. Okay, so the diagnosis has been made, fracture of the fifth metacarpal. All right, this line is to tell you there's soft tissue swelling there. No, boxers know how to do a punch. So do karate or martial arts people. They do this. People that don't know what they're doing do this. And that's how the fifth metacarpal gets injured. And it's either fracture, call that boxer's fracture. Okay, the boxers are supposed to know how to clench their fist, okay? But when I am in my fit of rage and I just do this, or the chin doesn't cooperate with my hand, I usually got some torsion, okay? That's not the important teaching point. The teaching point is when you have telescoping, in other words, if this is not normal in anatomic relationship, this joint is compromised, and so is this joint. So when you have, you're supposed to have this in terms of alignment.
Mhm.
When I have this, I've got superimposition. That shortens the bony component, but it compromises the articular cartilage here. And that sets this up. If this isn't treated properly, this cartilage is at risk of developing degenerative joint disease because this is messed up in terms of its length. Okay? And we do that in semester 8. Will you have patients who have trauma? This is an example of a patient who had trauma. Where did I leave my tool? Okay? So you can say, I don't want to treat extremities. All right, you'll be having to deal with them until you graduate. It's a choice you make. I think it's a wonderful area that will help you get into the 85% bucket of the patients that have never been to a chiropractor. Okay? Or what are you going to do when the patient's mother of the little boy brings in the CD? This was taken at the urgent care center, and they said there was nothing wrong. Would you mind taking a look? Oh, it's a skeletally immature hand. You've got a choice to make. If you want to dip into that arena, you're perfectly entitled to do that in the state of Florida. Okay, we have a good chiropractic act. You just have to realize you're going to have to find an age and sex match 8-year-old wrist to compare it against. Okay? I think it's a lot of fun. Little people heal quickly, heal well. All right, I really enjoyed it. Okay? So this semester is all about extremities. Or the patient says, I've got a cast on it. This is what a cast looks like. How old?
47.
47. This is not a normal scaphoid. All right? And you may have to x-ray the cast to see if it's healing properly. The orthopedic surgeon says, does your chiropractor have an x-ray machine? Yes, he can do it. Why does he not want to do it? It's not worth his while. Okay? So now they bring the patient to you, the cast is on. You are in a position to make a decision about radiographic evidence of healing. So if this was a week ago, this hasn't healed. If this is a year ago or 6 months ago, they should have taken the cast off. All right? But it's still not normal. So the teaching point, even now in semester 6, all trauma cases need follow-up x-rays 4 to 6 weeks later to make sure they have healed well. All, not some, but all. So in the previous example with the hand, if that was 2 or 3 weeks ago, that needs orthopedic intervention because this can't stay. They will open it up and they'll pull it apart and try to get as much anatomic alignment as they can because they don't want the joint compromise. Okay? So I guess the better question is, if you don't want to mess with it, say, that's not my area of expertise, send them to Dorian who wants to do athletic sports injuries. Okay? Most people are around. If they're pediatrics, there are pediatric radiologists, there are there's a pediatric certification, I think, in the chiropractic world, but I don't remember if it's one of there's 12 councils in the American chiropractic world. What does that mean? You get a certification process or there's an examination process of some kind at the end. You can take 1,000 hours of whatever postgraduate course you want to take. My suggestion is make sure you get a piece of paper at the end of it. If they don't give you a piece of paper, you cannot stand out because you don't have the credentials. Now we can argue whether the credentials are worth anything, but the point is you did the hour, you did the time, and you now have a document that says, I've got 100 hours in acupuncture, you don't have any, who would be deemed the more responsible person? And you know the answer. That's how the game gets played. Okay? All right, how old?
It's 54.
54, okay, this is a normal shoulder. This is still the surgical neck. The anatomic neck is between the greater and the lesser tuberosity. This is not normal, okay? You all see that. The humeral head should be inside the glenoid cavity like this, and it isn't, okay? She fell onto her shoulder, of all things, doing ice curling. What's ice curling? You push the rocks, Okay, she may have had her arm out too much and it dislocated, or maybe she was doing the broom thing. I don't know which it was.
Winter bowling.
Winter bowling, okay? Long story short, she dislocated her glenohumeral joint, which comes in semester 8. She went to her chiropractor. He took the x-rays. He says, I don't dislocate shoulders, I haven't had any expertise with that. So she went to the emergency hospital. The story I got is it took them 2 hours to reduce the dislocation. It shouldn't take that long. If it takes that long, they put you under anesthesia, and then it just slides back into place. The problem with glenohumeral dislocations is it has to come out of its articular bed. And when it does that, it disrupts soft tissues, including ligamentous structures, and that's how we get this. These are superior, middle, and inferior glenohumeral ligaments, the capsular ligaments, and that abuts pretty close to the brachial plexus, and that's why she had ulnar nerve palsy after this injury. Okay? I'm not going to reduce the dislocation. I don't have any expertise. The nurse on the ward or in the orthopedic department who said I've done this 20 times, I'm okay with that. Okay? But the problem is she doesn't understand or realize that when she reduces it, you're not so sure you haven't torn these, okay, and you can get some associated injuries with dislocations of the humerus, of the glenohumeral joint. Now, does it happen frequently? Yes, depending on what you do, and we've all heard of the fush thing, right? What's the fush thing? Falling on an outstretched hand. And when I do that, the forces work this way in the adult, okay? There are different mechanisms of injury in the skeletally mature individual because of their plasticity, all right? So predicting or being able to ask the patient, how did you fall, helps you in terms of deciding where should you look. So it was reduced as far as I know, okay? I can talk and ask Dr. Kubrick how his patients are doing that had this particular injury. This is, have I mentioned this site?
Yes.
Okay. If you want to know how to treat Osgood-Schlatter's disease on our dislocated shoulder on the PT side, this will give it to you, okay? The only thing we have close is this. I remember saying that, okay? So this is my go-to if someone asks me, well, how do you treat it? I don't know. Let me look at Physiopedia. Okay. And it's well done. They've got good information, just so you know. Okay, so that's upper extremity. I'll save the lower extremity for when we get there, but you get the idea. There's chiropractic physicians treating extremities an awful lot. If you become a sports chiropractor or you become involved in sports injuries, obviously you're going to be able to do, you'll be treating more of those. Okay, it just depends on what you want your wheelhouse to be. Okay, next one you want to load up is, you tell me what's on your list.